Hello everyone, welcome to Protein Metabolism. We are continuing with our lecture series on overview and integration of cellular metabolism, and today's topic is the second part of the continuation of last class, that is urea cycle. Over here we will be discussing the regulation of urea cycle and we will be also be learning the enzyme deficiency disorder. So, basically we will be covering these concepts. The first few concepts were already covered in the last class, and today we will be dealing with these concepts, that is regulation of urea cycle, the various enzyme deficiency disorder, how to diagnose and how to treat the urea cycle deficiency disorders. All right. So, we have already learnt how urea cycle is taking place. All right. We have learned how all the nitrogens are entering into the mitochondria, how they are getting prepared to participate in the urea cycle, and ultimately each and every steps we have all learned. Just for recapitulation, these are the important enzymes. The first enzyme was carbamoyl phosphate synthetase 1, which was required for prerequisite for urea cycle for the synthesis of carbamoyl phosphate. Subsequently, the enzymes are ornithine transcarbamylase, then arginosuccinate synthetase, arginosuccinate lyase and arginase 1. We also discussed mnemonics by which you can easily remember all the intermediates and all the enzymes, right. So, this is the sequence of urea cycle which was also discussed in previous class. So, I hope you can remember this slide. If you do not, it is good time to watch the previous class again and then attain this class according to your own pace. And as I have already told you, you should have by now drawn your own version of urea cycle with all the enzymes. So, now we can actually focus on what are those enzymes and what will happen if each of these enzymes are defective, and what will be the problems that will be leading to all the metabolic symptoms, right. So, we all know the final reaction was this: ammonia, carbon dioxide and 3 ATP was participating along with aspartate from TCA cycle. It was leading to formation of urea and fumarate, which was going into the TCA cycle, and ultimately 2 ADP, 1 AMP and 1 PPI. Now, over there I discussed that we will be reading about carbamoyl phosphate synthetase 1 in detail. Well, carbamoyl phosphate synthetase 1 has got an isoform or isoenzyme, that is carbamoyl phosphate synthetase 2. You should remember that the first two reactions are occurring in the mitochondria. So, definitely if we compare these isoforms, the first enzyme is taking place is actually located in the mitochondria, whereas the isoform is located in the cytosol, right. We all know CPS1 is a product of or is a component of urea cycle, but CPS2 we will be reading in detail very soon when we go into the nucleotide metabolism, is a part of pyrimidine biosynthesis. This point is very important. A positive effector of CPS1 is NAG, N-acetyl glutamate. Very important role it will be playing in the regulation of urea cycle. Next, there is no known effector of CPS2, right. What is the source of nitrogen to act on CPS1? It is ammonia, and for CPS2 it is glutamine. Is there any inhibitor of CPS1? There is no known inhibitor. So, if we have got an acceptor, it will increase more. If we do not have the effector, it will still go on. Nobody is there to stop urea cycle. Why? Because it is very important. If urea cycle stops, there will be many problems in our body, which is the discussion of today's topic, and CTP is the inhibitor of carbamoyl phosphate synthetase 2. So, looking at the nitrogen balance, this figure we are now very familiar with, or you can easily conceptualize. So, we are getting dietary proteins which are contributing to the amino acid pool. From there, tissue proteins are either getting synthesized or tissue proteins are breaking down to again contribute to the amino acid pool, and this amino acid can be reused to either produce important products or they can be excreted as ammonia and urea. All right. So, about 80% of excreted nitrogen is the form of urea. All right. So, how this urea cycle is actually regulated? So, there are multiple regulatory levels. Number one, basically there are two. One is coarse regulation and one is fine regulation. So, what is coarse regulation? Broadly, basically coarse regulation deals with inducing enzyme of urea cycle, basically the carbamoyl phosphate synthetase 1 as well as all the 4 enzymes of the cycle whenever there is an increased demand. So, when there will be increased demand? In case of high protein diet. In case of high protein diet, there will be more and more nitrogenous waste that will be produced, and there will be more and more urea cycle will be needed to get rid of those waste. Also remember, in case of prolonged starvation, where all the body's carbohydrate and lipids have been utilized, thereafter the body's nitrogen or the amino acids and proteins are broken down, where the muscle destruction occurs in the last phase of starvation after 72 hours or even after 3 to 4 days, right. So, neogluconesis is happening, then glutamate dehydrogenase is induced because catabolism of protein is happening, and that also increases the demand for urea cycle. Alright. So, what is the way of negating this whole thing? So, reverse way, I mean reverse regulation will happen whenever animals are well fed with diet that is rich in carbohydrate and fat. So, remember, high protein diet is actually inducing urea cycle, a diet which is devoid of protein will decrease the urea cycle. Also, animals with protein free diets, if we have diet plan as such that there are no protein in diet, then urea cycle will be suppressed because there will be no need of urea cycle. So, this is the coarse regulation, alright. Now, looking at the fine regulation is done by allosterically affecting the enzyme CPS1. I told you carbamoyl phosphate synthetase 1 is the most important or regulatory enzyme of urea cycle. So, who is actually the allosteric activator or effector? It is N-acetyl glutamate. So, if the body or if somehow we have more and more N-acetyl glutamate, it means there will be more and more activity of carbamoyl phosphate synthetase 1 and there will be more and more urea cycle. Now, there it does not end there. We can actually synthesize N-acetyl glutamate in the body by the help of glutamate and acetyl coenzyme A. You already know by now what is the source of acetyl coenzyme A, right, from carbohydrate metabolism knowledge and also lipid metabolism, and we already also know how glutamate is produced, right. Now, this enzyme N-acetyl glutamate synthase, alright, it synthesizes N-acetyl glutamate from glutamate and acetyl CoA. This enzyme can again be allosterically activated by the factors like high protein diet, more glutamate, arginine is a very strong activator of N-acetyl glutamate synthase as well as prolonged starvation. So, all those factors that was discussed in the course regulation along with high glutamate and arginine is actually activating N-acetyl glutamate synthase, which is leading to the production of more N-acetyl glutamate or NAG, and this NAG is actually activating the CPS1 enzyme, that is the regulatory enzyme of urea cycle, right. So, this whole process of coarse and fine regulation helps in regulating the urea cycle whenever there is an increased demand for urea cycle, alright. There is also another level of regulation which is actually biological regulation by the phenomenon of compartmentalization. What is compartmentalization? You are familiar with this figure where I discussed the first two reactions of urea cycle are taking place in the mitochondria, right, and the rest that is taking part in the cytoplasm. Now, how these proteins or how the molecules are transferred across mitochondria and cytoplasm? Well, there are dedicated transporter. For example, ornithine is transported via an ornithine transporter, citrulline is transported out by citrulline transporter. Few of these compounds are freely permeable by the mitochondrial membrane, through the mitochondrial membrane, they do not need transporter, right, but for ornithine there is a transporter which will also play a vital role during the urea cycle disorders. However, how the compartmentalization helps? Since the cycle is designed in such a way that few steps will be in the mitochondria and few steps will be in the cytosol, there is one step where fumarate is produced, right. Well, when fumarate is produced, the fumarase enzyme, alright, actually has got, you see, the inhibitory effect of fumarate on its own production is minimized because arginosuccinate lyase is in the cytoplasm while fumarase is in the mitochondria. So, what happens? This absence of fumarase is actually helping the cycle to continue, alright. Otherwise, what would have happened? The product would have been inhibited, it would have been feedbackally inhibited, but it is not inhibited in a feedback manner because the enzyme fumarase is not present in the mitochondria. So, where fumarase is present, it is present in the cytosol. So, when fumarate is coming out, it is actually broken down in the cytoplasm. Once again, fumarate, when it is formed, it actually, so how this basically happening? Fumarate is actually inhibiting its own formation. What do you understand by this? Means it would have inhibited the enzyme arginosuccinate lyase. So, arginosuccinate lyase actually breaks down arginosuccinate to form arginine and fumarate, right. So, if fumarate was present over there, fumarate would have inhibited feedback inhibition, but it is going outside. Why? Because it needs to replenish aspartate. Since it is going outside because fumarase is present in cytosol, the inhibitory effect of fumarate on its own formation is negated, alright. So, I hope I have already explained twice. So, I hope now it is clear. If it is not, you can pause the video, rewind back and rewatch again, right. So, looking at the amount of blood urea, the normal level is 20 to 40 mg per dl. This is a very common indicator of renal function that is always presented, prescribed by clinician whenever a routine blood investigation is given, urea and creatinine. Well, you have read about urea, we will be reading about creatinine later, right. And it is, since it is an indicator of renal function, when it will increase, physiologically it increases with age. So, the level of urea in a newborn baby will be much lower compared to the level of urea in an adult person, and it will be lower compared to an elderly. In elderly patient, the amount of urea increase will be high, normal range of urea, and pathologically in a disease process the amount of urea is actually increased with renal failure. Very important, it is not increased in protein intake, alright, very important, because whenever there is a balance, whenever the excretory system is working, no matter how much urea is produced by the urea cycle, irrespective, in spite of a high protein diet, urea will be cleared, urea will be washed out in urine. So, only and only if the excretion system is at fault, the outbound system is problematic, then the level of urea will rise, alright. So, let us return to the deficiency of urea cycle enzymes, which is a main topic of today's discussion. So, this is again an overview, alright. So, one thing to note is the first two steps are happening inside the mitochondria. I am repeating myself over and over again so that the thing is reinforced into your brain, and ornithine is transported into the mitochondria with the help of an ornithine transporter, alright. And the enzymes are carbamyl phosphate synthetase 1, ornithine transcarbamylase, arginosuccinate synthetase, arginosuccinate lyase and arginase, and these are the gene names that are coding for the, this is ornithine transporter is ORN1, okay. These are the genetic gene name of the genes that are coding for these enzymes, and everything is very important. So, considering the enzymes of urea cycle, each enzyme can be deficient individually, and there have been cases, individual cases that have been studied and well documented where each and every enzyme can be deficient, and ultimately they result in ammonia intoxication. Although the diseases of urea cycle are rare, that is 1 in 30,000 live births, but still cases are often found, because in countries like India where population is in billions, suddenly this 1 in 30,000, the number does not remain 1 in 30,000, it increases whenever we are talking about tertiary care center, especially the newborn clinic, right. You should note for MCQ purpose that all the enzyme of urea cycle diseases are inherited, all the diseases of urea cycle are inherited in autosomal recessive manner, except, I will again discuss it later, ornithine transcarbamylase deficiency, which is X linked, very important MCQ, alright. Now, the reaction 1 and 2. What is the reaction 1 and 2? The first reaction, carbamyl phosphate synthetase 1 and ornithine transcarbamylase, these two reactions are more concerned, I mean the deficiency of these two enzymes are much more serious because they lead to direct accumulation of ammonia, they are much more problematic, whereas the later enzymes, they help in accumulation of intermediates and they are less toxic compared to direct accumulation of ammonia. Alright. Now, we will be for the next few slides we will be discussing the few bits and pieces, few facts about urea cycle deficiency disorders, right. So, whenever an newborn is actually you see these enzymes are actually coded or formed in whenever the baby is in fetal stage. So, the deficiency of these enzymes will be manifested as and when the baby is born, right. So, this is a reason of congenital hyperammonemia. The term hyperammonemia again we will be discussing later, and we have also discussed it previously in our earlier classes, means an excess of ammonia, alright. So, whenever ammonia is acquired, when can it be hyperammonemia, when can it be acquired? Whenever the ammonia excreting mechanism is at fault, means liver failure. It was okay, but suddenly it has gone wrong. So, liver failure. And whenever a baby is born with urea cycle enzyme deficiency, it is a cause of congenital hyperammonemia. Now, most of it are partial deficiencies. Generally, total deficiencies are not found and they are very fatal, but still one or more of the several enzymes may be deficient and at least several days of time are given to the treating team by which they can diagnose and treat the disorder, otherwise there will be permanent brain damage. I already told you for the first few enzymes, the first two specifically, they are much more dangerous because ammonia is accumulated. On the other hand, the later stages, the multiple intermediates are accumulated that can diffuse from the hepatocyte into the blood and ultimately they are passed into the urine. Still, the collective features are mimicking ammonia toxicity. So, in general the deficiency of urea cycle enzyme are termed as hyperammonemia. And what is the feature of hyperammonia? It is a triad of actually hyperammonemia, encephalopathy and respiratory alkalosis. Very important. Now, we cannot extend our class in discussion in detail about acid base disorders, but please note that high amount of ammonia stimulates the medullary respiratory center to cause hyperventilation. Ammonia, medullary center, stimulation, hyperventilation, and hyperventilation means rapid breathing leads to washout of CO2, which leads to respiratory alkalosis. Alright. And ultimately ammonia toxicity we already know leads to features like vomiting, irritability, lethargy and severe mental retardation. There is depletion of TCA cycle, there are multiple neurotransmitters that are problematic. We have already discussed what are the mechanisms of ammonia toxicity, and if that toxicity happens right from the birth, there will be progressive and severe mental retardation. Alright. The baby may seem normal at birth, but with ongoing days they will become lethargic and activity will be very much compromised. Now, regarding the management or treatment, it is mainly symptomatic, right. So, whatever is the culprit, we need to identify and we need to treat, right. For example, we can actually decrease the ammonia or the effect of these deficiencies by letting these enzymes not act. So, these are urea cycle enzymes, right. When they will be acting more and more whenever the urea cycle is in full force. So, when or how can we decrease the level of urea cycle? We told you in regulation, low protein diet. So, low protein diet can actually restrict urea cycle. You know, urea cycle is also needed for synthesis of arginine. So, if we supplement arginine, the body will sense that okay, we do not need to perform urea cycle, and therefore, the intermediates of urea cycle, if there is some enzyme deficiency, will not be accumulated. All right. So, mainly these and frequent feeding by ultimately protein free diets can help in the ammonia level remaining low and prevent brain damage, right. I discussed ornithine transporter deficiency. It is a very important deficiency. It is not an enzyme, but it is a transporter. That is, if it is deficient, what will happen? Ornithine will be accumulated, right. So, ornithine gets accumulated leading to hyperornithinemia. Urea cycle will be hampered. What happens when urea cycle is hampered? It leads to hyperammonemia. And inside the mitochondria, what happens? Since ornithine is not available, right, lysine is carbamylated to form homocitrulline. Ultimately, there is an increase in level of homocitrulline. So, three things are increased. hyperornithinemia, hyperammonemia and hyperhomocitrullinemia. This is known as HHH syndrome, which is a diagnostic feature, which is a syndrome named in ornithine transporter deficiency. Again a very important multiple choice type of question from the urea cycle deficiency disorders. Now, you all know brain is very sensitive to ammonia. So, what is the regime? I told you, frequent small feed and low protein diet. Now, regarding the specific treatment, there can be some chemical agents that the mechanism of action which we will be discussing in later slide is to give intermediate, that is benzoate and phenylacetate. Okay. So, benzoate and phenylacetate or phenylbutyrate ultimately gets converted to soluble intermediates like hippuric acid and phenylacetyl glutamine. We will be seeing this reaction in detail later, do not bother right now, but know this treatment is treating with some intermediates which will lead to formation of soluble products that will be excreted, and thus the subsequent formation of these products will ultimately deplete the nitrogen from the system. If it is not clear, I will be again addressing this slide very later, right. Next, one thing to be noted, since citrulline is present in significant quantities in milk, right, there is a deficiency. You can tell it right now, when there is citrulline is acting, in what reaction citrulline is being converted to next product. If that enzyme is deficient, naturally citrulline will be accumulated and that will lead to citrullinemia. So, in case of citrullinemia, the breast milk is to be avoided, right, because already citrulline is increased due to deficiency of urea cycle. We do not need extra amount of citrulline from diet, right. Next, I already told you, for very important MCQ question, ornithine transcarbamylase is the only inherited urea cycle disorder that is X linked. All are autosomal recessive, right. So, increased levels of ammonia are also accompanied with high glutamine levels in blood. Why glutamine? Glutamine synthase, I already told you, glutamine synthetase, where glutamate is acted upon capturing on ammonia to become glutamine, and glutamine is the major carrier of ammonia. So, whenever ammonia is increased, glutamine will be increased, right. Next, arginosuccinate lyase deficiency. Well, if you want to follow these step by step, it is very important that you are also following the urea cycle that you have drawn. Then it will be very easy for you to locate what are the enzymes, and the product that is immediately before will get accumulated. This is the story of all enzyme deficiency disorder. So, the reactant on which the enzyme is acting will be accumulated, right. So, whenever there is a deficiency of arginosuccinate lyase, it acts on argininosuccinate, right, or arginosuccinic acid. Arginosuccinate accumulates in the body and ultimately it is leading to metabolic acidosis, right. So, arginosuccinic aciduria is a case where arginosuccinate is elevated in the CSF and it is excreted in urine, all right. A special clinical feature that happens in arginosuccinate lyase deficiency is trichorexis nodosa. It is characterized by friable and tufted hair. The hair is very much tufted and it easily breaks. So, this is a microscopic figure in which the breakage of the hair is being shown. It is broken internally. So, one gentle pull, the hair will be very brittle, all right. The most mild deficiency is actually the last enzyme deficiency, arginase. Mind it, whenever the upper enzymes are inhibited or enzyme are deficient, the diseases are much more severe, the manifestation is much more severe. As we move along the cycle, the symptoms become mild. So, in case of arginase deficiency, it appears within 2 to 4 years of age, right. So, how to diagnose these urea cycle deficiency disorders? Nowadays, and the gold standard of detecting enzyme of urea cycle disorder is by establishing the metabolites using tandem mass spectrometry, also 2 mass spectrometry that are coupled, or MS, okay, tandem mass spectrometry. So, this is again one slide which is showing all the disorders, right. I will be discussing all these disorders very soon in another table, but for now you should remember, whenever the enzymes are later enzymes, there will be increased accumulation of both arginine and citrulline. So, arginosuccinate synthetase, arginosuccinate lyase or arginase, they are characterized by increased arginine and citrulline. In case of arginase deficiency, there is more and more accumulation of arginine only, whereas the initial enzymes, that is carbamoyl phosphate synthetase 1 deficiency or ornithine transcarbamylase or N-acetyl glutamate synthase, the enzyme that was synthesizing NAG, they are characterized by decreased amount of arginine and citrulline, very important. So, later enzymes more arginine citrulline, former or earlier enzymes less arginine citrulline whenever we are measuring these amino acids in the plasma, alright. And regarding genetic inheritance, I told you OTC, the ornithine transcarbamylase is X-linked, other everyone is autosomal recessive. One important information, that is, if we measure the organic acid in urine in case of carbamoyl phosphate synthetase deficiency, there is normal or decreased urinary orotic acid, this is the marker, okay. So, next, high urinary orotic acid happens in ornithine transcarbamylase, and normal again normal or decreased urinary orotic acid happens in N-acetyl glutamate synthetase deficiency. So, if we look at these enzyme deficiencies one by one, the first enzyme deficiency, that is carbamoyl phosphate synthetase 1, is termed as hyperammonemia type 1, alright. It is characterized by severe mental retardation and developmental delay. Next, N-acetyl glutamate synthase is a variant of hyperammonemia type 1 because it is actually helping in the synthesis, helping in the enzyme CPS1, and we can actually treat that enzyme deficiency by treatment with N-carbamoyl L-glutamate, which actually activates CPS1. Why? N-acetyl glutamate synthase, the main job of this enzyme is to activate CPS1. So, if this is deficient, this enzyme is actually lowered, but if with this treatment, the whole thing is taken care of. Hyperammonemia type 2, ornithine transcarbamylase deficiency leading to orotic aciduria, alright. So, this is what happens here, the channeling of the intermediate to pyrimidine synthesis. Next, hyperornithinemia, when it happens in case of ornithine transport system disorder. Not only hyperornithinemia, hyperammonemia and hyperhomocitrullinemia also happens, right. Citrullinemia, when it will happen, the enzyme that acts on citrulline, that is arginosuccinate synthetase, if it is deficient, the product, the reactant earlier to it will be accumulated, right. Next, arginosuccinic aciduria, when it happens in case of arginosuccinate lyase deficiency. So, if this is deficient, this will not be acted upon, there will be more and more accumulation of arginosuccinic acid. The clinical feature trichorexis nodosa, we have already seen the photo. And lastly, most mild arginase deficiency, here what happens, arginemia happens because there is more and more accumulation of arginine inside CSF. Now, considering the level of ammonia in blood, it is actually very low, it is less than 50 micromole per liter, the standard being 11 to 30 or 15 to 45, whatever unit it is less than 50, right, depending on labs, unit of representation may be different. Whenever it is going beyond 100, the patient will start to lose consciousness, there will be altered sensorium, and if the value goes above 200, there will be coma and convulsion. However, this blood ammonia, generally it is whenever a blood ammonia is raised along with respiratory alkalosis in babies, that will lead to a clinical suspicion of urea cycle disorder, but in adults, mainly whenever ammonia is high, it is related to acquired or hepatic encephalopathy, and mind it, hepatic encephalopathy, the levels of ammonia are not well correlated because ammonia estimation may have some errors. Whenever fist is clenched or there is application of tourniquet or leading to processing time extension, ammonia level may be falsely elevated or lowered, right. And moreover, statistical studies have found out that the sensitivity, specificity, all those things, as well as the correlation of the disease, whenever the disease is cured, even then the ammonia levels appear to be very high. So, ammonia level is not a good indicator of hepatic encephalopathy in case of acquired hyperammonemia. So, how can we treat these urea cycle deficiency disorders? Mainly whenever we are restricting the protein, because protein free diet or low protein diet, we need to make sure the essential amino acids, our deficiencies are not hampered. How? We need to provide the corresponding keto acid in diet, because amino acids are converted to keto acid by transamination, and maximum calorie have to be given by intravenous glucose and lipids, right. Whenever there is block in a arginosuccinate lyase, we can supplement arginine in diet, because arginine is actually synthesized with the help of that enzyme, and in the first two blocks we can actually supplement with benzoyl CoA or benzoate and phenyl acetate or phenyl butyrate, which will give rise to soluble compounds that are excreted in urine. See over here, whenever there is formation or block in this enzyme, arginine synthesis will be defective, we need to supplement arginine, and this is how we can actually treat with external compound like benzoate. So, benzoate is actually combining with glutamine, is actually combining with all the glycine to form hippurate, right. Glycine is a amino acid that is extremely needed for all practical purpose. Also, phenyl butyrate is getting converted in vivo to phenyl acetate, and it is finally getting converted to phenyl acetyl glutamine. So, what happens? So, all the intermediates, that is glycine and glutamine, are now depleted from the system. Body needs more and more glycine and glutamine in order to excrete ammonia or to maintain normal metabolism. So, very important line, subsequent synthesis of glycine and glutamine to replenish the body pool of this compound actually removes ammonia from the bloodstream. So, we are actually indirectly removing ammonia by depleting their source. Their sources of the molecules which are actually produced from ammonia are removed. So, more and more ammonia will be utilized in order to produce this compounds. So, thus hyperammonemia will be treated. So, that is it about today's class. To conclude, the two lecture series on urea have been completed, and this lecture has covered the regulation of urea cycle, the various enzyme deficiency disorders, how we can diagnose the enzyme deficiency disorders, what are the symptoms and what is their treatment. So, these are the few references for my today's class, and I thank you all for your patient hearing. Bye.